Thank you, everyone, especially to our 4 incredible presenters. I was chatting with my friend Soraya, and we do a lot of work here in Massachusetts together. And we were just like, OMG, this is amazing. This is amazing. It is such a model for those of us that live in other communities outside of Detroit. And the work that you've done is incredible. So I just want to take a breath, right? We have, couple 30 seconds before we launch into our next session, and I'm sure our presenters could use a breath. So let's just all take a breath. Let's stand up, let's stretch a little bit, and then I'll get us started in 30 seconds or so. And to my presenters, you can go ahead and turn your video on if you're ready. All right, great. Everyone ready for session number 2? I am so excited to hear from some more of our colleagues from Michigan. We have a very Michigan-centric evening tonight, and really so honored to be able to facilitate this session tonight. So my name is Katie Shea Barrett. I am a maternal health advocate. I'm a maternal hemorrhage survivor. And I'm a member of the planning team for this symposium, along with Mary and Akeisha and the rest of us. So honored to be here tonight to facilitate this session called Creating a Culturally Responsive Asset-Based Strategy to Address Breastfeeding in African American Families. We have 4 amazing presenters that I will read the biographies for in a minute. I just want to send a couple of reminders at the start of this session. First, please help us keep this experience a safe space for everyone involved. Be respectful in your questions to our incredible panelists. Please feel free to ask your questions either in the Q&A or in the chat function. I will be moderating both to be able to save some space, and presenters, I'll give you a note just to say, we'd like to save a little bit of space for questions at the end, because I know the folks here are really eager to hear more from you specifically about their questions. And then finally, if you are following this on Twitter, like I am, please use the hashtags birth equity, hashtag PCOR, PCOR, or hashtag NMHPN. And if any of the presenters have Twitter handles that you want folks to tag you in, please feel free to put that in the chat as well. All right, so without further ado, and really to get the presentation, it's going to take a little bit to get through all 4 bios, but please bear with me. We have 4 incredibly accomplished women with us, so I want to do them the honor of reading their full biographies. So we have Donnie Ross, Mary Muse, Dr. Ijeoma Opara, and Dr. Angela Johnson. So almost doctor, not quite yet Dr. Donnie Ross will be leading us off. She is a joint Ph.D. student in social work and sociology at the University of Michigan. She's an alum of the Sociology and English Honors and the Ronald E. McNair Post-Baccalaureate Achievement Program at Wayne State University. Danae subsequently earned both her master's in social work and master's of arts in sociology from the University of Michigan. She has practiced both clinical and evaluative capacities in medical settings, including the perinatal, parenting, postpartum adjustment, and infant mental health programs. She's a recipient of the University of Michigan Rackham Merit Fellowship and the 2018 Inter-University Consortium for Social and Political Research Summer Program Diversity Scholarship. She is also the co-founder of a Black Girlhood Commons and a University of Michigan Rackham Interdisciplinary Workshop, and a co-organizer of the Black Feminist Kitchens 2020 Black Feminist Summer School. And one more, she's the co-chair of the Black Breastfeeding Caucus Research Committee. She is incredibly accomplished, y'all, so we're so lucky to have her. She brings an interdisciplinary social work and sociological lens to the study of Black maternal health. Donnie's work centers not only the physical, but the mental health of Black mothers and their infants and the sexual and reproductive discourses. She investigates how culture, particularly controlling images of Black womanhood, sexuality, motherhood, influence Black maternal health lived experience, as well as the health outcomes and decision-making relative to birth and breastfeeding. All right, so next we have Mary Muse. She is an international board certified lactation consultant. A lot of IBCLCs on the meeting tonight. She earned her master's of public health degree from Emory University Rollins School of Public Health, and she directs the successful African-American breastfeeding mothers research project at the University of Missouri in St. Louis. She recently completed a research study that examined the lived experience of Black African-American mothers who breastfed their babies and African-American grandmothers' intergenerational beliefs and perspectives around breastfeeding. She serves on the Black Breastfeeding Caucus of the Black Mothers Breastfeeding Association in Detroit and volunteers with the I Am Breastfeeding, an African-American mother-to-mother support group in Ferguson, Missouri. Next, we have Dr. Ijeoma Opara. She is an assistant professor of internal medicine and pediatrics at Wayne State University of Medicine. She is a graduate of the University of Michigan College of Liberal Arts for her undergraduate degree and Wayne State University School of Medicine for her medical degree. She's the founding director for the Health Equity and Justice in Medicine Initiative, as well as the co-founding director of the Global and Urban Health Equity Program. As a clinician, she cares for predominantly African-American and low-income populations and practices asset-based, family-centered, culturally sensitive primary care that takes into account the social and historical context of her patients in order to produce the best possible health outcomes for the community and families that she serves. As a researcher, she studies the role of resilience and hopefulness in maternal health outcomes, as well as how anti-racist, culturally sensitive asset-based systems can improve breastfeeding through her work as a member of the Black Mothers Breastfeeding Association Research Task Force. She's a clinician educator, and she develops and implements curricula on health equity, structural racism, social justice, social determinants of health, to medical students, resident physicians, and practicing physicians. So she basically does what the recommendation from the PCOR agenda was at the beginning of this. She does this in practice. She is also a physician advocate and activist and works with multiple community-based organizations, legislators, and other stakeholders to address both upstream and downstream determinants of health outcomes. And last, but certainly not least, we have Dr. Angela Johnson. She is an applied social scientist, research scholar, advocate, and published author in the area of maternal and breastfeeding health equity. Her work is community-focused, mother-centric, and designed to highlight psychosocial risk factors to inform the development of interventions that enhance racial and social equity for moms and their families. Dr. Johnson's research has informed maternal and child health programs, policy, and research. Her work is published in virtual outlets, national and international peer-reviewed journals. Dr. Johnson is trained as an NIH-funded postdoctoral translational science fellow at the Michigan Institute for Clinical Health Research at Michigan Medicine, University of Michigan. She earned her Ph.D. and her master's degree in sociology and urban affairs from Michigan State University and her Bachelor of Arts in psychology and Black studies from Amherst College here in Massachusetts. Dr. Johnson leads the development of education, training, and research programs designed to reduce racial and other social inequities for two divisions at Michigan Medicine, the Program of Multicultural Health in the Department for Community Health Services, and the Zero to Thrive program in the Women and Infant Mental Health program. She's also a mom of 3. So I am super excited to turn it over to Danae, who will share her slides and be the main slide presenter. Please remember to put your questions in the Q&A and chat, and I will send you guys a signal that when we have about 10 minutes left, around 6:50, 6:55, so we can do some questions. But without further ado, I introduce Danae Ross.
Thank you so much, Katie. We are so pleased to be here. We want to thank you for the opportunity. We're very excited to be presenting our preliminary findings and our work with you. So our breakout session is entitled Creating a Culturally Responsive Asset-Based Strategy to Address Breastfeeding in African-American Families. Before we get started with our actual presentation, I want to take just a moment to uplift our team. We have worked tirelessly, and our team has worked with us. So we want to lift them up. We want to acknowledge them. They have performed abstract reviews, sat through trainings and full text reviews, data extraction, and have been so supportive since our formation of the Black Breastfeeding Caucus Research Committee. So Joanne Allen, Alexis Barr, Angela Hamilton, Yolanda Jack, Tamika Jackson Dyer, Isabel Morgan, Tia Murray, Michonne Tarver, and we also want to thank the Black Breastfeeding Caucus. So our learning objectives for today are really to recognize the important role that structural racism has played in creating the current or contemporary breastfeeding and chest feeding racial disparities. We want to understand important culturally sensitive asset-based social ecological strategies to address and improve breastfeeding and chest feeding rates among Black families. We want to list some community-driven solutions that we were able to observe through our research and through our discussion and practice wisdom. Then we want to move on to looking at and exploring some actionable and integrative multi-level strategies that engage stakeholders at multiple levels and lift the voices of Black women to ensure that they are at the center of advocacy work as it is taking place to address upstream structural factors that impact breastfeeding and chest feeding disparities. So I will turn it over to Angela, Dr. Angela Johnson, so that she can give you a little bit of background.
Thank you, Donnie. Heartfelt thanks to the National Maternal Health PCOR Network. Thank you, Katie. Thank you, Keisha. And a special thanks to this wonderful panel, my fellow colleagues who have been so gracious and wonderful to work with. I just really want to, put that out there. Sometimes I can forget how wonderfully blessed I and we all are. This is a wonderful opportunity to connect. I realize that this vast wealth of knowledge, expertise, passion. So I'm honored to be amongst all of you today. And I hope that I can serve and simply serve. Our fellow previous panelists said it well, that I can serve in a way that's meaningful, and so that we may all be blessed with increased understanding and power. So what I hope to do with a few minutes that I have with you today is to discuss some of the background information on breast chest feeding experiences for African-American mothers as it pertains to some of our objectives. And so for many of us, this will be a review. I often feel like sometimes we're preaching to the choir, but you've heard, especially, here from practice, from research, from all of the advocacy work to bolster breastfeeding among Black moms and babies. But what I hope it does is that at the very least, it will serve as a reminder, and it will help set the stage for all of the other presentation information that you'll hear, the wonderful information you'll hear tonight. So next slide. So first, we really want to begin by reviewing, and really I think it's a review of some of the benefits to breast chest feeding, as well as some of the risks of not doing so, in other words, formula feeding. So we know from extensive practice and research work that breastfeeding has many, many, many health benefits for both moms and babies. That breastfeeding babies, for instance, reduces risk of ear infection, respiratory infections, GI infections. That breastfed babies are said to be less likely to develop asthma, diabetes, less likely to become obese. Mothers who breastfeed have lower risk for developing type 2 diabetes, hypertension, breast and ovarian cancers. And these are just to name a few. Protections from breastfeeding are not just physical. Mothers who breastfeed or chest feed overwhelmingly enjoy psychological and emotional benefits from breastfeeding. The bond between mama and baby is strengthened and established, of course. Moms often, it's one of the favorite benefits that I hear moms speak of when I'm doing interviews and focus groups in the community. They talk about that faster return to that pre-pregnancy body, losing all that, we don't like to use the word fat, but baby fat. So overall, we know that there are tremendous positive impacts for moms and babies who are able to breastfeed. It's quite the privilege. But of course, there are risks for not breastfeeding or formula feeding, chest feeding. And they are as negatively impactful as much as the benefits help mothers. So for babies, for example, not being breastfed is associated with increased incidence of numerous problematic health outcomes: childhood obesity, type 1, type 2 diabetes, leukemia, SIDS, sudden infant death syndrome, of which we know our community disproportionately suffers. And for moms who are unable to breastfeed, there are at-risk chances for increased incidence of premenopausal breast cancer, ovarian cancer, type 2 diabetes, heart disease, risk factors. And I could think, sort of from the personal perspective a bit, my mother's generation, who were systematically told that it was not beneficial to breastfeed, who many, like she and my family, suffered and died from chronic diseases like hypertension. Next slide, please. But unfortunately, despite the extensive benefits that breastfeeding provides to moms and babies' health, breastfeeding initiation and maintenance rates, the duration among Black women, remains persistently lower and than rates among all other groups of women. The rates are said to be about 10 to 20% percentage points lower. So that's about 3 to 4 times lower than breastfeeding rates for all other women. The current statistics indicate that breastfeeding initiation rates have increased, but unfortunately they have not kept pace with the rise in breastfeeding initiation duration exclusivity among all other women. Next slide, please.
What's happening?
So what we've come to understand, in addition to lower breastfeeding rates, is that African-American women, Black women, are also disproportionately more likely compared with white women to have poor perinatal health outcomes, to suffer from chronic illness, stress, depression, post-traumatic stress disorder, all of which are known risk factors associated with lower breastfeeding rates. Morbidity and mortality, which are essential, ironically, to our well-being and our longevity, are suffering. Next slide, please. What I think is also worth noting, and as our previous presenters so well demonstrated, is that the COVID-19 pandemic has hit the Black community hard. COVID-19 rates for racial and ethnic groups, particularly for Black and Brown communities and families, are much higher. The Black community, according to recent estimates by the CDC and Johns Hopkins, it says, although Black Americans make up only 13% of the US population, they constitute anywhere from 30 to 40% of COVID positive cases nationwide. And unfortunately, the death rates are much higher as well. Recent estimates are that about 71% of deaths due to COVID-19 are experienced by African American. It's heartbreaking. It's really heartbreaking because this is something, it's too proximate and it's too near and dear to all of us. To hear, testimonies like Jennifer, that my heart goes out to Jennifer and those who've lost family to COVID. I lost some family members as well to COVID. Next slide, please. So why, despite all of the tremendous benefits that breastfeeding or chest feeding can give to Black women, and why, despite the negative impacts of not breast or chest feeding, why do breastfeeding rates remain persistently low? Next slide, please. Well, what we've come to understand, and I think we've heard excellent testimonial information regarding, is that there are plethora of underlying contributors to racial health disparities, including breastfeeding. And that we can think of these in terms of this kind of ecological systems approach, that it's overlaid across many layers of what make up the social fabric of society. That there are just so many layers that work in concert and that make the true difference in terms of being able to pursue positive health outcomes and behaviors, such as breastfeeding. Though they're individual factors, they're interpersonal factors, institutional, policy, and macro systems. And we can think of these more simply in terms of things like lack of access to educational opportunities, workforce, health and wealth opportunities, that these are chronic, these are systemic, and that such things as racial discrimination likewise are systemic and that happen over a lifetime and across multiple generations. That living in racially segregated neighborhoods and communities is still all too commonplace. And that experiencing racial disempowerment is all too commonplace. We understand from a kind of psycho-emotional perspective that because discrimination increases the volume of stress that one experiences, Black mothers and their families are particularly vulnerable to adverse health impact in its various forms. And unfortunately, conversely, Black women are more likely to lack the critical social support in healthcare and workplace, that Black women are more likely, for instance, to return to work much sooner on average than all other mothers who are in the workforce. And then unfortunately, violence in all of its forms and methods operate throughout history and currently to form these kind of mutually reinforcing systems of oppression. There's lack of investment in funding, lack of investment in resources, and not just in our Black communities, but in academia, where knowledge, information, and understanding might be proliferated in ways to impact community and other programs. Next slide, please. So unfortunately, much of the current research and programs fail to adequately recognize the tremendous role that structural racism has in lowering breastfeeding rates among African American and Black women. So this slide, I thought we were pretty enthusiastic about, very excited, in terms of the way it clearly visually demonstrates this long historical injustice that's wrapped around breastfeeding disparities, that chest and breastfeeding differences in the Black community are associated with wet nursing. And wet nursing has a long history, long legacy, unfortunately, in our society, in our community. And when Black women were treated as chattel during slavery, there were horrific acts of violence placed upon them. Experimentation on slave women was very commonplace, often without an anesthesia. Forced sterilizations on Black bodies and other exploitative practices have left an indelible mark. And they currently operate as a very catalytic force from our collective consciousness. So that really, lots of folks like to believe what was then is then and what was now is now. But what we really like to reinforce to people in these discussions around this topic is that the current mistreatment of birthing and Black women and babies, and that the families is really just a continuance of long global history of mistreatment. Next slide, please. So I guess in closing, I really want to impress the importance of this ongoing negative social cultural legacy, that it has these very broad roots and broad reach. And that lest we forget that the legacy of exploitation and mistreatment extends not just to mothers and babies, but to the entire Black community and Black families, so that her story, right, her story, which is impacted, of course, by macro systems of our social fabric, institutional systems, and community, is the Black community's story. The effects of things such as over-policing, the epidemic currently that we're experiencing as a continuance of police killing of unarmed Black citizens, the mass incarceration, the overrepresentation of Black bodies in the US prison system, alongside our underrepresentation in education systems, exacerbate the burden that Black women and Black families, Black communities face as providers for our nation. And so, really in closing, I just have to say, there's far more that we could discuss in terms of these topics. Happy to answer questions, but it's just important that we think about the context of breastfeeding disparities And the inability, it's not the lack of capacity, it's the inability based on these social limitations and restrictions for Black mothers and babies to maximize the benefits of breastfeeding and chest feeding. Thank you.
Thank you, Angela. So I am going to take us through the current study at hand, which was keeping all of the structural violence, all of the historical origins that Dr. Johnson just brought to bear on this conversation in mind, as well as the overwhelming amount of deficit-based literature that exists. So we have first of all, our multidisciplinary interprofessional research team is comprised of folks who self-identify as Black with preferred pronouns of she, her, hers, that they bring to bear on this work theoretical and experiential expertise, which is emphasized in Dorothy Smith's standpoint theory. And we also bring a subjective and objective approach to the work emphasized by Collins in Black feminist thought. So many of the members of the team have themselves breastfed, attempted to breastfeed or chest feed. And so they bring that as well as their work in communities to bear on this. And that's the lens that we're using to delve into the literature and into the methodologies and studies. The different expertise that's represented on our team includes nursing, public health, we have international board certified lactation consultants. We have Black Mamas Matters membership, medicine, social work, African-American history, culture, and arts, as well as social science academics trained in multimodal research methods, so qualitative, quantitative, and mixed methodology represented on our team. The scoping review process. So the method that we chose to use in order to engage in this work is a scoping review. The purpose of a scoping review is typically to examine the extent or the range of the research activity that has already taken place, or to determine the value for undertaking a full systematic review. So a systematic review is a little bit more rigorous and systematic than a scoping review would be. So the scoping review can serve as the first step to determining whether or not the study and the topic warrants a systematic review. It also can be used to summarize and disseminate research findings, which we're always interested in terms of sharing our results with the community. So hopefully what we will do with this study once we finish is to create a practitioner toolkit that can be disseminated throughout the community based on our findings here. We also will, the scoping review can also be used to identify research gaps in the existing literature. So the 5 stages of the scoping review are to identify the research question, identify relevant studies, select those studies, chart the data, and then collate and summarize and report the results. And there's also been a call to advance the methodology such that you include quality assessment for the included studies in the review. So a little bit about our methodology. We chose to use English language. We had capacity for French within our team, but not enough in order to expand our horizons in that way. So we wanted to make sure that we were constraining it to our capacity. We also chose the years 2010 to 2020. And we chose to use peer-reviewed articles. We looked for empirical studies with measurable outcomes related to initiation and duration. We focused on all African diasporic people in the US. We constrained it to the space of the US, recognizing that we did not want to decontextualize the experiences of folks in other geographic locations. And we also were inclusive of donor milk. So our study is based off of the work of Robinson from 2019, as well as the work of Dr. Johnson from 2015. And we chose to expand it or advance that knowledge and build upon it by including donor milk and also including chest feeding and infant feeding with human milk. We had intense discussions within our committee about what we were most interested in learning. And what we decided was that we're interested in learning about the array of different experiences that exist in terms of feeding with infant milk, with human milk. We were most interested in human milk more so than the way that you got that to the baby, right? And so we recognize that there was literature that's been produced in nursing, over 200 articles cited by one study talking about chest feeding experience. And we struggle to find as much literature about chest feeding and infant feeding for trans folks, for non-binary folks and what have you, for trans and non-binary Black folks. So we're looking at chest feeding and infant feeding, hoping to expand gender inclusivity within this conversation. We also established our search strategy in PubMed based on the approach that Dr. Robinson used in her study from 2019, and other databases that we intend to explore or are interested in exploring are the Web of Science, CINAHL, Social Services Abstracts, PsycInfo, and Family and Society Studies. Our analytic methods are also rooted in Dr. Johnson and Dr. Robinson's studies, such that we will not only include from Dr. Johnson's study the social ecological levels of the interventions, as she discussed earlier during the presentation, but from Dr. Robinson's studies, we'll also look at the quality and the level of the evidence for included studies. So our results from the preliminary review, we looked at 1,864 abstracts, reduced that to 152 full texts. They emphasize the significance of social support, so peer-to-peer support, familial support, online community, as well as community breastfeeding and chest feedings via community breastfeeding clubs. But we also found something that was really interesting, which is the unique and positive effects of other interventions on breastfeeding initiation rates among Black women and parents. So we did find that breast cancer education was connected with increased initiation in some studies, as well as religion. So Muslim education, religious education was also connected with increased rates of initiation, and Muslim education with duration as well. We also found that nursing quality was connected, policy, so the Affordable Care Act, of course. Limited focus, however, was found on Black IBCLCs. There was very little literature that focused on the work that Black IBCLCs are doing and how that support increases the initiation and duration rates among Black parents. We also saw a need for amplification and clarification of the multiple uses of donor milk. So uplifting donor milk, some studies discussed it as an intervention that would assist in the initiation of feeding with human milk from the body, whereas others saw it differently. So there's some need for us to really clarify and to talk about all of the different uses and lift up donor milk. Increasing inclusivity by combating anti-Blackness. So we want to, based on our review of the literature, some of the things that we see that really need to happen in order for us to move this literature in the right direction, of course, are to think expansively about the Black lived experience of feeding with human milk. So one of the things that needs to happen is that we decouple the anatomy of the body and gender. There's a lot of coupling of women, mothers, a lot of discussion of breasts, whereas folks may not identify as having breasts, folks may not identify as having chest. There are different ways of identifying, and so we need to expand our language to be inclusive in that way. When we come into a room, if we say, you know, are you planning to breastfeed? That in and of itself assumes that the person who gave birth identifies as having breasts, and then beyond that may, you know. So there are implications around decoupling anatomy and gender. Also de-emphasizing hetero and mononormativity. So the literature really does emphasize monogamy in relationships and heteronormativity. There are relationships, of course, where folks have more than one partner. And so we want to be able to accommodate families as they show up in different structures. We want to make sure that we are supporting them the best that we can. And so we're going to push the literature to think through some of these issues and to explore them. As well as the intersection with FAAP politics. There was no literature that was looking at FAAP politics, and we cannot be pro-Black or work for Black communities, but not think about what it means to show up in a healthcare setting Black and attempting to breast or chest or feed with human milk your baby. We also want to see more integration of the physical and mental health outcomes and think through some of the spiritual dimensions and whether or not that has an effect. We did see the literature on Muslim education, religious education, but it was very sparse. So we want to see more of that proliferated. As well as increased attention to complexities and historical traumas in medicine. So what we didn't find was a lot of work on, and trigger warning, sexual violence. We didn't find a lot of work on the association between sexual violence in Black women and how that trauma history was affecting initiation and duration. We do expect that we will find that in the other databases that we search. So for instance, CINAHL, a nursing database, or social services abstracts, we're hoping that there'll be more integration and more attention to the trauma histories, but we see that that's not happening in medicine. And so we really want to ask the questions why and how is this being tackled? Other intersecting axes, there was not very much literature on teen moms and support specific interventions that were set up to support Black teen moms in their endeavor to breastfeed. And so we want to see more literature along those lines. In addition, this must not only be reflected in our approaches and our practices, but also in our language. So we want to follow the lead of the Journal of Human Lactation, which recently asked that breastfeeding be revised to infant feeding or feeding with human milk. And so we want to think about how we can be more inclusive in our language, as well as in our ideological or philosophical approaches and practices as a result of all of that. And then there is a need for increased attention to the historical context. A lot of the studies that were included based on our criteria did not delve into the historical context. They would talk about the contemporary health outcomes and the disparities, but there was not a lot of attention to or connection to the historical context. It seems that that is being segregated from some of the studies that are actually testing initiation and duration. We want to see that integrated. So we believe in the practice of reflexivity, and we also believe in the practice of transparency. So with respect for our own research, the fact that we're focusing on peer review, the fact that we're focusing on empirical evidence, initiation and duration, implicitly privileges a particular type of literature, which is probably quantitative, which is well-funded, which is longitudinal work. And we know that there is a bias that is against other kinds of work. And so the scoping review methodology, some of our own criteria in and of themselves are reproducing this colonial approach to research methodologies. We want to acknowledge that here in this space so that we can push our work in the right direction and also model the behaviors that we want to see from other researchers in the future, which is reflexivity and transparency about the work that we have yet to do. In addition to that, longitudinal qualitative research requires access, relationships, and rapport. So if it requires longitudinal qualitative research requires access, relationship, and rapport, then we know that that then could lend itself to more Black researchers being able to do that work if we uplift that kind of work, because the access and the relationships and the rapport are more likely to be able to be built thinking about interviewer effect, the accuracy of data collected if we have matching in terms of our positionalities. All right, so I'll turn it over to Mary for the community voice portion.
Okay, can everyone hear me? Can you hear me? Okay.
Yes.
My bandwidth is low, so. Okay, thank you so much, Donnie. We're going to be focusing, or I'm going to be focusing on our community voices, and you can move on to the next slide, Donnie. And within our community voices, excuse me, what we decided that would be best that we look at our community from an asset strength-based narrative and approach. So I will be covering that along with the family and community centeredness, and then also looking at examples of community-driven solutions. So you can move on to the next slide. So with the asset-based narrative approach, first, let me start off by saying that with our group, we, as Donnie has mentioned, we are a national collective of self-identified Black service providers, advocates, academics, and other stakeholders, and we are committed to the equitable breastfeeding support for Black families. So what we knew is that coming from an asset strength base, we looked at our internal resources that we have within our community. And even within our task force here, who are all African-American women, 90% of us or more have breastfed or are breastfeeding our babies or chest feeding. So this allowed us to have the opportunity to have culturally sensitive discussions about how breastfeeding is being conducted within our communities. So we began to form collaboration with other African American lactation support groups. But with that, as we have begun to look at the literature as Danae has so beautifully described, what we need is not there in the literature. So we've had to also look across disciplines. And as Angela has pointed out earlier, with the history of wet nursing, we have looked at the works of Dr. Stephanie Jones Rogers and her work, or her book, which is titled "They Were Her Property: White Women Slaveholders in..."
Oops, we may be having, oh,
That
Mary, do you want to try turning off your video? It may preserve your bandwidth. And we have about 2 more minutes and then we have to wrap up.
2 more minutes? Oh my God, okay.
Sorry.
So anyway, as she looked at, what she'd argued is that for African American women, the whole wet nursing business niche was created by white women in the slave economy and not necessarily by white men as we had once thought so. So basically, in a nutshell, is that white women have profited off of Black women's breast milk, and that's still even happening today. There was an example that happened maybe a couple of years ago with Black women in Detroit, where the Mother's Milk Cooperative and their partners, Medilac Laboratories, that they solicited African American women for their breast milk and was willing to buy it for $1 per ounce. Medilac was going to process it, sell it, and then sell it back at a 600% markup. So also within that, a part of our goal, along with the scoping review, is to also develop this environmental scan to where we have scanned our communities, and therefore we are creating a database to where we are identifying lactation organizations within our community that are providing that service to families. Okay, you can advance. Next slide. Can you hear me?
This is the next one.
Oh, okay, sorry. So as we look at the family and community centeredness, as we have pointed out that the majority of the literature review has been basically qualitative, there's not enough information that's focusing on the voices of African American families. So with breastfeeding mothers, they have created what we have called like a breast list or a chest list. And really this information is coming from the qualitative research that African American researchers have done, to where Black women have spoken up and said, okay, this is what we need to be successful, such as we need someone who understands our issues as far as breastfeeding in the community and what's interfering with that, such as Angela pointed out, mothers having to return to work early. Also, not enough access to Black African American IBCLCs, and also being introduced to the options of human milk and also exclusively breastfeeding. So what we have begun to do is to communicate to breastfeeding families, as Andres pointed out, the benefits of receiving mother's milk. Okay, next slide, please. So just a few examples of how we have come to begin to identify community-driven solutions. Although we did not create this problem, we are still left in our community with having to solve the issues that we are dealing with. So one such example is the Mama Moba Milk, and they have already explained themselves out of Detroit, and then NOLA Baby Cafe. And so these are collaborations that we are forming within our group. Now, NOLA Baby Cafe in New Orleans has the lowest number, or the lowest breastfeeding rate in the country. And so as a result of that, they created the NOLA Baby Cafe. And then here in St. Louis, where I'm located, we have the I Am Breastfeeding group, which is another mother-to-mother African-American support group. And actually this group was just featured back in 2018 in the Journal of Human Lactation. And they are also being driven with coming up with solutions as to how we can lower or increase the breastfeeding rate. Can you hear me still? Okay, move to the next slide. So now COVID has hit, and as the previous group has pointed out, there has been many challenges with that, such as engaging the whole family while you're trying to social distance. And then what does that really look like? It has really forced us to go to, using our technology much better. There's also the struggle with Black IBCLCs being in practice, being able to provide services such as telehealth. And then also even with the changes in WIC, where there has been an increased availability of formula relative to the decrease of chest feeding and breastfeeding services that are being provided. And then just overall, some community-based organizations have just had to shut down altogether. And so, but there have been some opportunities. We have been able to really encourage mothers to breastfeed their babies in order to avoid their babies becoming sick, so that they would not have to be placed in the hospital. There's been an increase in virtual learning opportunities, such as what's happening here, because if COVID wouldn't happen, then it would be difficult for us to travel. And then also having access to the multi-level networking opportunities with, lactation consultants like ourselves and other stakeholders.
Okay, so I will be very quick about this, because our time is far spent and I want to respect the time. Next slide. So essentially, we have a call to action. After hearing these glorious voices and these glorious ways of thinking and all that has been shared, what's next? How do we pivot to action? And so we have a call to action, and it really starts with decolonizing our ways of knowing, because research produces the knowledge which informs policy and practice and informs education. And so in order to inform and change those downstream effects, we have to decolonize the ways we know. And we acknowledge that that process is it is ethical, it is ontological, and it is political. So when we talk about decolonizing research and solution strategies, what we are talking about essentially is putting our community of Black families, Black women, femmes, families, communities at the center of the process of engendering and generating knowledge. It means that we are essentially beginning to deconstruct what it means to know, whereby quantitative, for example, knowledge or epistemologies are not what is valued at what is higher or more evidence, and then qualitative devalued. So it challenges what is valued as what is knowledge and what is evidence. And we call it out at all the entire how will I say, supply chain of knowledge production, all the way from how research question is developed, how it's funded, even to dissemination. There are even very practical ways of, again, decolonization, even as something as basic as authorship, whereby community partners are placed as first authors and everybody else just follows an alphabetical order. And that just, again, flattens the process and of all aspects of knowledge production and living out. It also, there's an encouragement for introducing frameworks that are originated from the community. So womanist frameworks and Black queer frameworks and studies, intersectionality studies, all to be integrated into this process of knowledge generation. So there is a strong need to decolonize the ways we produce the knowledge that informs the process, the practice, and education. Next. And so we'll go through the rest very quickly, because all the rest kind of feed upon that. So what does that also mean? It means that we need to develop, fund, and invest in culturally responsive, congruent, appropriate, respectful, valuing, honoring, asset-based inclusive initiatives, programs, strategies, and studies that promote Black breast and chest feeding. It means that we establish evidence-based best practice guidelines for these activities that are informed by and driven by Black women, femmes, and non-binary folks, and are led by, I have to also emphasize, next. It means increasing, growing and diversifying perinatal researchers and practitioners and consultants and all of that by funding them, valuing and disseminating their work, and might I say by compensating them at every stage of their work, okay? It means supporting policies such as the Black Maternal Health Momnibus Act of 2020 that was created and sponsored by the Black Maternal Health Caucus and led by Senator Kamala Harris and Congresswomen Underwood and Adams, that essentially will work this legislation to work to eliminate disparities in maternal health outcomes and address, if not simply end, maternal mortality, especially as it relates to Black women. Also, Family Leave Act, the FMLA, expanded that, making sure it's paid and that is prolonged even beyond that 12 weeks so that folks can establish and enjoy breast and chest feeding with their child without worrying about economic insecurity. And ultimately, at the end of the day, we want the narrative when it comes to breast and chest feeding as it relates to Black women and communities and families to change, to normalize it, to say that this is integral to who we are. We've always breastfed, we are breastfeeding, we will continue to breastfeed. That needs to be the assumption that then underlines and underpins our efforts. So we want to normalize it, we want to change that narrative, move it from that deficit-based model and individual-based model to a more collaborative, community-centered, and with not just our voices, but our ways of knowing at every step of the narrative that then feeds into research, feeds into policy, feeds into practice. And with that, I want to thank you all for your attention. Thank you all for your graciousness and your accommodation, even as we went past the time. We're grateful and we want to open up for questions if the organizers feel like there's time.
Thank you so much, Donnie, Mary, Dr. Angela, Dr. Ijeoma. That was an incredible work. Your inclusive approach, your driven approach should be a model for everyone. We are over time, so I'm not going to open it up for questions, but Donnie has very graciously offered everyone's contact information here on the slide. So if you